Right, it seems like it's slowed down a bit, so if anybody else comes in, they can miss the first slide. Good evening. Welcome to the grand finale of the Community of Practice for now. This is session 8. Welcome to anybody who's not been here before and all the familiar faces out there. We'd like to start with an acknowledgement of country. And in the spirit of reconciliation, we acknowledge the traditional custodians of the lands on which we meet, the Wurundjeri people of the Kulin Nation. We pay our respects to the elders past and present and extend that respect to all Aboriginal and Torres Strait Islander peoples today, for they're the safekeepers of memories, traditions and culture. We recognise their connection to country, land, sea and community and the role in caring for and maintaining country over thousands of years. May their strength and wisdom be with us today. So that's a bit of housekeeping for people who aren't familiar. It's Zoom meeting. If you are muted, please keep your microphone on mute. If you want to ask a question, you can use the chat box at the bottom of your screen. We'll be monitoring that live time and bring up your questions, every question at an appropriate time. If you want to contribute verbally, please do. We love people speaking up. Just raise your hand or unmute yourself and ask to say something. The session is being recorded and you'll have access to the recording, and please ensure you join the session using the name that you registered with so we can mark your attendance. Unfortunately, certificates in CPD cannot be issued if we can't confirm your attendance. So how to change your name in a Zoom meeting, I'll let you read that. You click on participants app, click on your name, find desktop, hover on your name, click the 3 dots. And if you're on a Mac, hover on your name and click more, and then rename. Okay, and you can click done after that. So introducing your facilitators, we have the lovely Catherine Chen with us, one of my co-facilitators. She is a general paediatrician at the Royal Children's Hospital and in charge of the short stay unit there. She also works with safer care and research positions. She has been co-facilitator for the whole thing and is a fantastic resource of information. And I am me, that very close-up picture. I'm a GP in Truganina in Melbourne's West. I was originally trained in hospital medicine, transferring to the bright side several years ago now. I predominantly see paediatric patients and I've always had an interest in asthma and chronic disease management. The agenda, we are going to recap every session we've had. So all 7 sessions, you're going to get a flyby whole-stop tour of them with the highlights, the resources. Some of the presenters will be joining us and going through updates since their session. And there'll be an opportunity to ask questions, bring cases forward at that point. And then after we've recapped, there will also be some free time. And if you're working up the courage to bring up a case or a clinical question, please do so. Again, for anybody who is new to this session, it is an open forum where there are no silly questions. We want to answer everything, and you've got some of the greatest minds in paediatric asthma care across the country here tonight, so please do. So at the end of this session, you'll be able to implement best practice management for asthma in children, describe the resources and local services to Melbourne's West available for children living with asthma, identify collaborative multidisciplinary opportunities to improve care for children living with asthma, and hopefully interpret some local data and identify potential solutions to improve asthma care locally. So this is the opportunity we'd like everybody to introduce themselves in the chat with your name, your organisation and your role. This is a multidisciplinary meeting, so we have asthma nurses, we have pharmacists, we have stakeholders, we have paediatricians, we've got ED physicians, we have GPs, we have lots of people here, so it's really nice. Danny is here with his dinner. Thank you, Danny's Dinner, for joining us tonight. So yeah, feel free to say hello so we know what we're working with. I will now hand over to Catherine to go through the beginning of the recaps.
Thanks, Kirsty. I just noticed that Loretta's hand is up. Laura, do you have a question before we start?
No, sorry, mistake by me.
That's okay. So just travel down to the very first community of practice. For those that have attended, my screen. Okay, perfect. Our first one was on adolescent asthma. And what we started off in that session was to show you the data around the inner west. And that really highlights what we're focusing on the inner west. As you could see on the orange dot at the very top, in all age groups, children living in the inner west local government areas have higher number of admissions or presentations to emergency compared to their metropolitan peers. And that's why the focus of this project have been on the inner west. The red box there highlight the adolescent group. Even though they are not the most number of presentations to emergency, I think they're particularly vulnerable groups. We see lots of young children, but the group that often land in ICU or we hear rare reports of mortality, it's really in this adolescents. And that's why we started our community practice on the adolescents. That we brought up the case, but I think the main learnings or main discussions of that community of practice is that consistent with the newest international guideline, that all adolescents should be receiving either a SMART therapy, and that's a combined budesonide formoterol medication as required, or the standard therapy, and that is regular inhaled corticosteroids. In other words, there probably should not be any adolescents using just salbutamol or Ventolin itself. So that was the key highlight of the community of practice. During the community of practice, there was also a lot of discussions from community services that the hospitals may not be sending discharge planning information that's suitable. And I think that leads to a lot of changes from the hospital. And I think that shows the power of this kind of forum where we all come together and share our experiences. And that was one highlight of this community of practice for me. I might flip over to Kirsty so that she can share her learnings from this community of practice.
Yeah, so as Catherine says, it was a great first community of practice, really sort of honing in on what we wanted. A bunch of multidisciplinary professionals involved in asthma care talking and troubleshooting. A few days after the community of practice, I was reached out to by the community asthma programme to discuss really how could they communicate better with GPs when they had issues. And some of the feedbacks that we've had was some lack of confidence consulting with GPs or making suggestions to GPs. And we discussed practical approaches, how you could organise case conferences, and how letters are just picking up the phone. We want to discuss with the stakeholders in our patients' care. We want to have better communication. And since then, personally, from the community asthma programme in my region, I've had multiple referrals. I feel very confident to pick up the phone and chat with them. They are very well educated. They're a great source for me and resources for my patients. And I feel we've developed in the last 6 months a really great working relationship for a resource that is literally 5 clicks down the road from me and I didn't know existed. So it was a really nice example of how these things can improve local asthma care.
I think one of the other great learnings and we quickly discover in the first community practice was there's actually a lot of resources for asthma out there. I think the challenges of all of us working in the front line is knowing when they exist and how to look for them. So in each of these topics, we have put links to some of the key resources that we share with everyone during that community of practice. You have access to the slides and we will put all the links in a Word document when we send it out. I think Jason has also put the links into the chat if you wish to look at it during the presentation. I think one of relevant to this community of practice is a SMART action plan, which is slightly different from the action plan that we're currently using, and I think particularly tailored for adolescents on the SMART therapy.
I would just make another point for the GPs who are attending who haven't been before. One of the issues with asthma care is having enough time to do it, and having ramped up my asthma patient list, shall we say, since joining this. Finding time's really difficult, and it's really difficult, as I'm sure I don't need to go into the details, to do a care plan for them because often they don't meet the criteria of having 3 service providers. So using the community of asthma programme, who I refer almost all my young people with asthma to, at least for initial sessions to follow up on what I've discussed, was a brilliant way to get that extra provider. Obviously, any allergy secondary care services, respiratory secondary care services, other complex needs services, using the pharmacist for medication reviews, inhaler techniques, and practice nurses. We troubleshooted some really useful resources, so we could actually fund our time to be able to see these patients for longer complex appointments, as opposed to trying to shoehorn it in on the usual busy day. So I hope that's a useful resource for you all.
Thanks, Kirsty. So before we move on to the second community of practice, just wondering whether I'm just opening up to the floor, if anyone would like to share their learnings from the adolescent
I think we're
asthma,
having,
or if anyone have any places.
we seem to be having a little bit of an issue with your link up, Catherine.
Sorry.
Oh, I think you're back now. No, you've gone.
Can you hear me now?
Yeah, it's coming in and out. It's a little staccato. It's coming in and out, but
okay. Shall I just maybe I'll stop my video to see if that helps a little bit. Can you hear me better? Okay. I think I was sorry for cutting out. I was saying before we move on to the second community of practice, just wondering if anyone want to discuss any things that we discussed regarding adolescents, or share a case at this point regarding adolescents.
if anybody from the community asthma programme wants to say how their experience has been, very happy to accept constructive criticism here and feedback, or reaching out to other GPs how you found it, because I know that I've spoken to a lot of you multiple times, but wondering if you found it easier, the similar reception to other GPs, have your referrals increased? All quiet just now. We'll maybe let you have a think about it, and we'll come back to you at the question and answer sessions.
Sorry, Kirsty, I wasn't able to unmute.
All right. I wasn't looking at you specifically, Mel, but I was looking at you.
Right. I thought I should represent some of us community asthma nurses. So as you know, Kirsty, I've had dealings with you too, with one of our little patients. It's been fantastic to have that rapport to develop for the patient. That's been an absolute, it's really enhanced the way we can communicate. Also, this particular child has got a lot of other allergies and anaphylaxis, and quite a parents are really engaged, wanting to do the right thing, but just unable to get that consistent message. So it's been fantastic. That's just one example of us working together, which has been great.
I would say on that patient as well, something that I think we found quite interesting was the messaging that patients bring back to you. It's one of those first things you learn in medical school, certainly in GP school, is check the understanding. And there was lots of mixed messages, and everybody involved in the care, from the children's to community asthma team to here, had been doing these sessions. We knew we were on the same page, but every time this patient came back, they had a slight variation on what they thought they had gleaned. So it was really good to be able to phone each other and say, we're pretty sure you didn't say that. Did you say that? And clarify, so we could go back and between ourselves make sure the message was consistent, get the wording right, see how we'd approach this patient. We have a high number of call communities as well, so English as a second language we're always bearing in mind as an issue, and whether we need to get, not for this patient, but translators in. But it was a really nice way just to be able to phone your colleague, which we don't get to do in the community, with such regularity, and say, no, we're all on the same page, consistent messaging, it just needs to be reinforced a few more times.
Yes, right,
All right. Thanks, Mel. So moving on to our second community of practice, and with this one, we mainly spoke about seasonal triggers, particularly allergic rhinitis and thunderstorm asthma, and we were very fortunate for this one. Am I not clicking? Yeah, to have Dr. Erin Chambers that joined us, which is GP working in Queensland, and Dr. Danny Sutoris, which is with us today. So I think the main messages, this was just a lovely photo showing the COVID lockdown, reducing the number of presentations with asthma, but also, as you could see, the blips that are predicted when we have exposure to pollen, that increases the rates of emergency asthma presentations. So what the key messages that we discussed during this session was really important when we manage children with asthma, that we need to manage the coexisting allergies. So that's allergic rhinitis, eczema, and food allergies, because we need to reduce the overall load. But also we know that children with food allergies, for example, can be life-threatening if their asthma is poorly controlled. It is one of the biggest risk factor of a bad outcome. If your asthma is poorly controlled and you have anaphylaxis with a food allergy. So in this session, we spoke about how to manage allergic rhinitis. And I think the key messages for me was to use inhaled corticosteroids. You can start that from a very young age, is to use a long period of time. And I think Dr. Dean Tay and Dr. Erin Chambers were saying sometimes in 6 weeks, 3 months, keep going, high doses, and checking that technique was really important. Only a very small number needs to be referred to the Children's Hospital for desensitization. And Dr. Sosaros shared with us some of the apps and information regarding thunderstorm asthma. So at this point, I might hand over first to Kirsty to share sharings, and then we could see whether Danny wants to share anything else with us when he's online. He's online today.
Yeah, thanks, Catherine. Clinically, from a GP perspective, I think that nasal corticosteroid is something to be really important on. It's quite an easy thing as well in clinic to remind yourself to ask when you've got those sniffy kids in, especially in September to January. The allergic rhinitis link at the top there has really nice video via Asthma Australia, which you can get directly through their website on how to administer nasal corticosteroids. I would say a bit like inhalers with spacers, it's almost always done incorrectly and it really does make a difference. My take home for desensitization was the main message, and please correct me if I'm wrong, but what you're hoping for is a up to 50% reduction in sensitization to allergies. So you're really looking at that extreme end of the spectrum for things that we think it's going to make a significant lifelong difference. I get a lot of people asking about desensitization with, you know, mild hay fever symptoms, and now my messaging really is it's probably just not worth looking into in the private sphere or the public sphere, and it's more for those more severe children, multiple atopic children. And yeah, I think I'll let Danny chat about thunderstorm asthma if he wants to make some comments perhaps on what he's learned from the programme, if anything's changed in his work, and any take homes he would really love us and the participants who haven't been here before to remember about thunderstorm asthma.
Cool. Thanks for that. I wasn't prepared for this, but look, I guess the thing that I would be thinking about is the upcoming season. We're thinking it's likely to be a El Nino season, so hotter, bigger winds. We've just had lots and lots of rain, so we're expecting there's going to be lots and lots of grass ready to grow. So I guess I'm worried a little bit about this season coming up. It's been 7 years since the big one, and it doesn't come every 7 years, but it's almost, we're sort of almost expecting one to come, and I'd hate it to be this year. So I guess I'd encourage everyone to sort of think about hay fever and asthma as being those flags to speak about thunderstorm asthma. Predominantly if you get seasonal allergic rhinitis in Victoria, it's typically related to ryegrass, and we think ryegrass is the trigger with those particular storms coming through. And to start the conversation with patients and friends, community, anyone about the risk. And, the simplest thing, if you just got hay fever, manage your hay fever, but stay out of storms in grass pollen season, and get indoors. If you're not exposed, you're not going to have any problems. If you've got asthma, have good asthma control and know what you're going to do during those days. And pointing to the websites, so Vic Emergency is where we put up our forecasts. You can also get them from the department or from Melbourne Pollen. And knowing that tomorrow might be a high-risk day, you might want to change your plans of going to the park and having a lovely time, if a storm is coming. So there's really some good preparation work that, you know, really could save lives. And by the by, if you're talking about this stuff, it may be a way of getting people who are a little bit bored of their asthma to take a little bit more interest in asthma, because, you know, thunderstorm asthma or epidemic thunderstorm asthma is pretty sort of exciting and engaging sort of topic. Lots of people sort of will tune in, and it's a good hook to, you know, get that asthma action plan, you know, in front of people and get them to take this stuff. I might stop there.
Thanks, Danny. Sorry to put you on the spot, but we know you do a really good job. You did. Thank you very much. Okay.
I would just say very quickly, I remember, Danny, the take home from that as well was this, you'll see on your screens the Book Emergency app with an update for thunderstorm asthma events. I found that really interesting. It's not every storm. There are specific markers that it's going to be a thunderstorm asthma event. So it's not just looking at the Bureau of Meteorology and seeing a big storm's coming through. There's some specific advice on that, which I found very interesting and definitely changed the way I was messaging to parents, patients and parents.
Yep. Yeah, it comes in the form of low risk, moderate risk, and high risk. And the high risks, you know, they don't always occur, but, you know, they're the times to really pay attention to. But yeah, it's a nice website. Tells you all sorts of interesting other things. I encourage everyone to have a look later tonight. Vic Emergency.
Thanks, Danny. So moving on to our third community of practice, it was on our community asthma services. And I think this was a particularly useful one. We were joined in this session by Naomi Auburn from CoHealth and also Louise Hoda from Asthma Australia. I think for many of us, it was just an eye-opener of the resources available in the community that sometimes perhaps we haven't fully utilized. And it was really useful to hear Naomi and Louise speak about the kind of work that they do. And I think from a hospital perspective, we often see children and parents are very tired. There is often a rush to be discharged because there is beds in demand. And perhaps some of the messaging and education may not be fully completed, or they may have more questions when they go home. And the community asthma service have that opportunity. They have more time. They can go through the education, the action plan, recheck techniques for the families. A lot of our asthma nurses have the opportunity and will be able to visit the families in their home, which is really, really helpful because then they can discuss about some of the environmental exposures that are in the home. Some of our asthma nurses even support the families when they see specialists or their GP and act as that connection. So it was a very, very useful resources. And over the next few slides, we have put in again some of their contact and referral pathway, which you have access to when we send you the slides and the Word documents. And just briefly, the Asthma Australia pretty much cover, doesn't matter where you live. However, CoHealth and DPV do have certain postcodes that they service. Even if you do get it wrong, that's okay. Our lovely nurses will let you know and direct you to the best service. So that's not a barrier at all. Kirsty, should I hand over to you?
Yeah, I suppose just from a general practice point of view, these are now two resources that I include generically on the blurb at the beginning of any of my paediatric asthma care plans. So I put that in part of the resources. And I often make the parents take down the 1-800 asthma and log it in their phone and say, it's natural to have questions after this. You can phone them tomorrow if you can't get an appointment and you've got a pressing question to go through. They pick up to an asthma educator. It's not an automated service. It's not callback. 9 to 5, Monday to Friday, and they can access it themselves. So it's become sort of standard part of my practice. And I've already talked about how helpful I found the community asthma programme.
So for our hospital, we also inbuilt their referral into our software. So it's a quick click for our busy doctors working on the floor. I'm just interested in whether there's any questions regarding the community asthma service and whether any of the community asthma team would like to share whether their practice have changed, whether they've been flooded with referrals since we opened up and had this session. Oh, thanks, Amy. You add it to your template too. It's great.
Have you, Amy, I know you're speaking for them, but have you found the GPs have found it useful in your practice to add it to the template? Do you feel that the messaging is more convenient? Are they using it more?
So yeah, I've actually developed an asthma care plan template, and it's got the contact details for CAPS, and then I've got added I did a presentation about the CAPS to my GP, so they're aware of the service. I am an asthma educator, so I try and see them myself in the hour consult, but every patient that I see, I still give them the option to see the CAPS program as well, because it's government funded. The hardest thing with general practice is I've got to justify my time, and unfortunately I don't have funding for like the CAPS nurses. So I do see them, but I'm always trying to link people in with resources. Same with like the allergy. The biggest change that we did was we added the action plans with the Asthma Australia. We tried to incorporate that, but we've been doing a lot of allergic rhinitis. Probably 50% of my patients were having allergic rhinitis uncontrolled and weren't getting treated correctly. The biggest thing is about the medications, the changes. So it's just, I wish there was a little bit, clearer resources, like as a snapshot for GPs to understand medications and the changes. That's going to take a bit of a while to filter through. Then part of the template is linked to a lot of the videos and asthma resources. So it's just having that already pre-populated for GPs to use at hand instead of trying to find all the resources themselves.
That sounds like an amazing resource, Amy. I feel like we should fund you to roll that out to the Western suburbs through the PHN, because it is one of the biggest barriers. Asthma, previously we had cycle of cares for those who weren't aware, and then that sort of got taken away, and it's listed, if you look at GP management plan, example of chronic illness, asthma's up there, it's asthma, diabetes, and then the rest, but you can't do it because there's often a lack of services that you can add to have the three providers. It feels almost a bit weak to say it's the pharmacist and the practice nurse unless they're specific asthma educators,
Yeah, it's not easy, but you can always just do a care plan, and I'm lucky that my GPs support me, and I have my own chronic disease clinics, so that hour of writing up care planning is actually fully asthma education with them, and then I follow up with them using my nurse item numbers, but it's only $12. So a lot of the time I do provide them the details to self-refer to CAPS, because they can, I'm de-skilling unfortunately, but because it's the funding model, where when I had asthma cycle of cares, I could actually justify the financial side of it, and the other ways is doing more spirometries. So, that things as well is important as well. But yeah, all the item numbers have been reduced.
Have the GPs given you any feedback, Amy, about whether they feel their education level has increased, their practice has changed?
Definitely. So in the data that we entered into ICAMS is the doctors actually were never assessing their technique with the spacer. They were asking them, they were talking about the education, but not physically assessing them. The flip chart has been the biggest change in my practice. Kevin provided us with the asthma flip charts. So now that's in every consult room. So now everyone's getting asthma scores, so it's just having that readily available. And I did an hour and a half presentation with the pediatric respiratory physician. So that helped doing a lunch and in-house about it. And I sent all the doctors the information about the CAPS as well. So they had that to read afterwards and get familiar with it. So this program, I think, is fantastic. Like what you've done with the community access, I think that needs to be mirrored with other forms of like diabetes and other chronic diseases, because it's linking us all in.
I'm just looking, Kevin's just said flip charts coming soon in different languages. Would you, Kevin, like to update?
I did not know that.
Just quickly tell us about the flip charts and how we can get hold of them?
Yeah, sure, Kirsty. We were funded through the ICAM project to provide flip charts to all of the GPs. within the 3 LGAs. But we've also managed to secure funding to look at the 3 languages in those LGAs, which is primarily Arabic, Vietnamese, and Chinese. So we've sort of got a modified version of the flip chart, but it's still as big and still as condensed. But it's something that you could share with the patient, or if you've got those language skills yourself, you can talk to the patient to them. So yeah, those things will be coming soon, and unfortunately we won't get it out until around July. So but we'll be here to be able to distribute that resource. And in addition to that, I just might also mention we've also produced an asthma action plan video that's now on the website. That's currently, we've got the English version up there. I'll provide the link in the chat. But that's also going to be translated into the 3 languages as well. And we're just probably by the end of June we'll have that available too. So yeah, we've certainly, hopefully we'll have the languages covered in terms of, and it's good to hear that feedback from Amy that the GPs really like the flip chart. So yeah, we're happy with that. Thanks.
I would have to say at the hospital too, we also are lucky now to have a copy of the flip chart. And I think the benefit of that is when you are explaining, to be able to point to pictures, and also those flip chart, you can actually wipe. So we often have lots of sneezing and coughing kits on it. Between each patient, we'll give it a wipe and we can bring it over to the next room. So if you're able to leave a link or somewhere that people could order from you, that would be lovely. Otherwise, we'll head off to the Asthma Australia website to look for those resources. Thanks, Kevin. So moving on to the next community of practice. In this one, there was a lot of discussion, and it was on preschool wheeze, which we then decided that perhaps is more appropriate for children that are Ventolin responsive, that are recurrent, to be using the consistent language of asthma. Because I think we hear from families that the naming and calling could be really confusing and uncertainty of what they do. And if we give them some certainty that this is preschool asthma, this is how you manage it, we may have more of a consistent plan. So our lovely respiratory physician, Dr. Shiv Shanti Kumar, was the expert for this session. Ooh, let me just go. Rachel, do you mind moving back? I can't seem to. Actually, okay, I'll just stop here. So what we might do is share some of our key learnings, and then I might just invite Shiv to share his perspective, and also to share with us the new clinical practice guideline that's coming out for preschool asthma. For me, the key learnings here, other than the language, was that this group of children, there is not a lot of evidence for the oral corticosteroids. And in fact, there is the risk of harms in terms of the steroid exposure, the effect on growth, that oral corticosteroids for this group in preschool children should be reserved for hospital use. We also heard from Shiv that there's more and more evidence and support around for those with a phenotype of recurrent wheeze and more severe exacerbation. Putting them on a course of inhaled corticosteroids may reduce the number of exacerbations and the need for salbutamol or Ventolin. First, I'll flick over to Kirsty to share her learnings, and then Shiv, if you're ready, for you to share your perspective.
I'm just flicking through the participants, Catherine. I wonder if Shiv's got held up with something. I can't see him. I'll maybe let someone see if he's there. Certainly, this has been one of the biggest changes in my practice, and I'll run through from a GP perspective for everybody new here and if you maybe haven't been aware of the changes. So Catherine said, as I say, it's this constant messaging. We're forever saying, oh no, you're just a bit wheezy and infection. This is a viral trigger. Oh no, it's just allergic asthma. We were getting more and more patients coming back saying, my kid's not got asthma. Why do they need an asthma action plan for daycare or school? Is this asthma? I go to, so we've got 3 different ED departments who serve our practice, 4 if you can, if you use the smaller ones as well. Somebody tells me it's just a virus. Somebody tells me they've not got asthma. Somebody says I do have asthma. This change in messaging, and I think everybody who was on that that community of practice really signed up to just calling it what it is. We're differentiating between those children who have the ability to bronchoconstrict and respond to Ventolin and those who don't. There's plenty of children who get recurrent coughs and colds and are not atopic and never wheeze. And there's plenty of children who maybe it happens once or twice. And then there's that demographic that we all have who are wheezy 50%, 60%, but they're still told this isn't asthma. And it's confusing and really is just nomenclature, and it gets everybody on board. It makes sense why we're giving them asthma plans and a Ventolin and telling daycare that it's asthma. And I discussed this, Shiv, a few times about why we thought asthma care was not getting as good outcomes, and part of it was this devolution of care to the patient and to schools. And if we're going to continue to give asthma plans and give quite high level advice and management to parents and patients and schools, we really need to be clear and consistent with what we're telling them so they can do it well, as opposed to getting mixed messaging. So I think that was one of the biggest things. The second biggest change of practice for me was I was quite familiar with using Flixtide Junior in younger patients because I just have a huge number who fall into that atopic, allergic, recurrent viral wheeze, and it was usually me writing to paediatricians saying, oh, I think we should go on some Flixtide. But what I also see is huge numbers of oral steroids. And a nice case that was referred to me from the community asthma programme last week was a 22-month-old boy who had 10 courses of oral prednisolone for 3 days by their GP in the preceding 18 months. So from 6 months old, he had a course every single time he had a cough or a cold. And he had been up to ED a few times and up to the children's the last time, who said, look, you need to be going to the community asthma programme. Luckily prescribed Flixtide Junior, so I can now do it without any hassle. Saw the brilliant nurses there and they referred to me, and we've had 3 appointments over the last 10 days, and the family are very appreciative. They understand he has asthma, even though he's only 22 months old. This is asthma. We had our final consult for the next month today, and they just really felt supported. They felt they understood why we weren't giving oral steroids in the community. We were managing this with Flixtide and Ventolin, and if the requirement was that he was not holding on his 6 puffs of Ventolin 3 hourly, he must go to hospital, not have oral steroids in the community. And I think Shiv's explanation that really the only evidence in the under 5s is that oral steroids prevent against ITU admission, and that's a stat I say to patients, because often I'll have parents saying, just give them steroids because we need to get them back to school. I need them to get better soon. You know, some of them want them to have steroids because they perceive they get better quickly. And the way I've been explaining that to sort of combat that really difficult emotive situation is saying, hey, look, the evidence for this is if I'm giving you steroids, what I'm saying is I'm doing it to prevent an ITU admission. And if I think I'm giving you a treatment to prevent you going to ITU, I am not sending you back to your house to manage that at home. So they're either coping in the community with their spaced Ventolin and good asthma education, and you've brought the puffers in, and I've made sure you're using a mouthpiece. That's the other thing. I've been using a mouthpiece from 18-month-old. If they can suck a lollipop, they can use a mouthpiece as opposed to the face mask. And they have not been having steroids. They're going up to hospital if they're not stretching. And I think that was probably the last learning outcome, was using the mouthpiece much younger in children. It was probably 3-4 I was starting to say, look, let's get off the face mask. But I think through education from the community asthma programme and in my own practice, often when they're giving the Ventolin to a child who doesn't want to feel claustrophobic because they're struggling to breathe, they're moving and they're also nose breathing a lot, and they're just not getting the medication in. And the amount of children who parents have brought in said, I don't think it's working. And then we've just taken the face mask off, got them to use the mouthpiece, and the change in their symptoms, the instant benefit, has been huge. And before this project, I never would have said to an 18-month-old, or it's usually the pretty well 18 months that we're playing, they're not sick, but certainly from around the 2 age, I've not had one who's not been able to use the mouthpiece. So they're my 3 learning outcomes. Messaging of asthma, not various types of wheeze, no use of oral steroids unless you think they're going to hospital, in which case you're sending them to hospital, and using the mouthpiece and removing the face mask.
So Shiv is not here, but on his behalf, I just want to say that preschool wheeze was identified as an area of need quite early on the project, and Shiv, along with a lot of collaborators, have put together a clinical practice guideline that will be published on the Royal Children's Clinical Practice Guideline website, hopefully by the end of this month. One of the key issues that they've highlighted, as I was reading some of the messages, is how do you diagnose when is wheeze become asthma? I think the key is what Kirsty's saying, if they're responding to Ventolin and being quite confident and say that's asthma, and we give you a plan so that you know what to do. But what the CPG was really useful for is a steps up and step down. And one of the key important part of this clinical practice guideline is when do you delabel and de-diagnose? Because as we know, a lot of these children, probably around 1 in 4, 1 in 5, do not continue to wheeze or have asthma in school. And therefore, it's equally important in that group to say, well, you grow out of it and you don't have asthma. So I think that's how I think parents often get on board with it when you explain to them, this is what it's called because that's how we treat it. So we know we're in the same page. But also, your child may very well likely not have ongoing wheeze and need Ventolin. And at that point, we will delabel and not call you asthma anymore. So that was an important point of that CPG that will be coming out shortly. Just wondering if anyone else wants to share their experience with preschool asthma, some of the challenges they have with it, or any questions they have around this area.
Or if anybody who's new today wants to ask questions about what we've discussed, because it was certainly one of the biggest changes of practice for us. I think on the Flixtide use, Shiv had said really no exacerbations for 6 months. You can de-escalate their Flixtide. No exacerbations for a year. You can say that's it, done and dusted for now. I don't know if anybody else has found, but when you look, if you look at the asthma handbook, the GINA guidelines, it all has the escalation of treatment, and often it says it's talking about textbook asthma. You know, it's talking about medical school asthmatic patients. It's not really catering to the preschool wheeze, and it says continuous of morning symptoms. But when you get these kids in who are wheezing really only an infection, sometimes it is difficult to say, well, when are they needing Flixtide? And as Catherine said, that background risk, so the atopic kids with anaphylaxis, kids with chronic rhinitis, kids with family history of atopes, you're building up this picture of really, well, I've seen them 3 times already this year with wheeze, and they've got all of the above. They're probably needing a trial of Flixtide. You know, it's early in the flu season, and we probably want to be doing it. The ones I find more difficult, and I don't know if Catherine, you can, or anybody else can glean a light, is those ones who don't have those background risks. They just are 50% of the time they're wheezy and infection, and they manage very well on Ventolin. And they don't. So I had one in today, but they don't have a family history of atopy. The older sister did not have, preschool asthma, and those ones. I have one she's on her 3rd wheezy episode, but she's equally had 3 where she's not been wheezy, and I'm thinking, you don't have any of the risk factors and you do really well on Ventolin, and you've never been to hospital, and you've never needed oral steroids in hospital. So what do I do? Do I wait till she's had 5 or 6 wheezy episodes this year before giving her Flixtide? Do I call it at 3? They're the ones I'm still a bit confused at.
Yeah, and that's quite a big group, because a lot of our preschool asthma wheeze group are really quite episodic, and they're relatively well in between with hardly any interval symptoms. They are mild. And I think if they're just infrequent users, as you describe, and has not had any severe exacerbations, it's quite okay to give them a plan and just use Ventolin as required. And that's quite a reasonable way. And I think a lot of children will just be on that.
Yeah, that's what I felt. I just felt like when we give these resources as well, and I was looking through it again, and I was like, it really doesn't cater to that group because this is quite new, and it is quite confusing as a GP when you're reading it going, they don't have chronic symptoms. Yeah, they might cough for a bit longer than your average child, but 4 weeks of cough after a good going infection, it's kind of normal. Then they get something else on top of it. So, is it postnasal drip? Is it asthma? All the questions we've been going through. But I think, yeah, that puts it nicely. It's really those higher risk kids that we're putting on Flixtide. But if they're managing very well with a few days of Ventolin, they can carry on. Thank you.
All right, so moving on to our next next community of practice. In this one, if you remember, we actually invite a few consumers or families to join us. We have, I think, a 12-year-old adolescents. We have a few parents who spoke about their experience, and we even had a Vietnamese-speaking family who had a translator with her. And they each share their stories about their journey with asthma and some of the challenges and learnings. And we heard lots of positive feedback from you. Some of you felt that was really important to hear about the patient's perspective and their needs. Some people highlight that it's important about simplifying messages. I think we all have our opinions. The evidence may be conflicting, but at the end of the day, we need to think about from the parents and the family's perspective, how do we make things as simple as possible for them? And I think that come back to why we changed some of the language around preschool asthma, just to make things a little bit more simplified from the family's perspective. I guess before we move on to the Flixitide issue, would Kirsty or anyone want to share their learnings from having the consumers with us for that episode of Community of Practice?
I don't want to pick on our lovely asthma nurses, because they are so generous with their thoughts. But I feel sometimes, especially with the wealth of time you have, you often can get a different perspective. I wonder if it changed any of your practice, if it made you think differently about clients. Did it just reaffirm everything you always knew? I don't know if we've got anybody here who was there.
While we're waiting, I just want to highlight, Jason just put on the chat some links. So one of the partners of this project is CoHealth, and they were tasked with self-management. They created lots of videos and also some of consumer stories, and that link below. We won't have time to show all of it. So if you're interested, the link and the resources produced by CoHealth is in the chat.
I'll just bring up a question or a point Mel's made that's very valid, is just to clarify, using the mouthpiece with the spacer in the under 4-year-olds, not just, well, like all spacer use, but not just taking parents' words for it. And I would say that's definitely been a change in practice. If my asthma patients don't turn up with their meds in the spacer, they're rebooked by me there and then for the next available time they can come in to bring it in. So when I say I'm doing it with the kids, I mean, I'm literally saying, you bring in your spacer, you bring in your puffers, I'm showing you how to do it. And then what I tend to do is at the follow-up appointment, which is usually a week later, get them to do it again to confirm they know how to. They then have the Community of Asthma team who will follow up. And I'm doing 3 monthly for the littlies inhaler technique with our practice nurse. And I think the GINA guidelines is 6 monthly, but I think when they're kids and adults are responsible for them, I've been doing it 3 monthly with either a pharmacist, who luckily we have on site, the practice nurse, or myself.
All right, well, let's move on to the issue of the Flixitide Junior. I think a lot of you online will remember almost like an April Fool's joke on the 1st of April, out of the blue. We were notified without a lot of warning or explanation that Flixitide Junior was delisted, so it's no longer on PBS for children over the age of 6. And for those children less than 6, from the 1st of April, we require specialists, and that's a pediatrician or respiratory physician, to provide an authority script. And this obviously creates a lot of issues with access. As you know, it's very hard to get children seen in a specialist clinic in such a short period of time. And in our understanding, it was nothing to do with the efficacy or side effects of Flixitide Junior. I believe it has more to do with the drug companies and funding issues. I think this highlighted the benefits of us working together and the collaborative efforts. So many of the GPs on the call today, along with SHIF and through multiple professional bodies, actively lobby and wrote very strong letters to PBS, advocating for Flixitide Junior to remain on PBS. Particularly, it is the only preventive medications that we mainly use for children less than 6. So very happy to say that the PBS have reversed that decision. And so I think that only come in effect from November 2023, that you'll still be able to prescribe Flixitide Junior for children less than 6 years of age without any restrictions. However, the part that hasn't changed, Flixotide remain off PBS for children over the age of 6. This is probably less of an issue because children over the age of 6 do have other options, such as the beclomethasone, higher dose of Flixotide if you need to, and also more and more of us are using ciclesonide or Elvesco because it is once a day. Even though it's more expensive to buy because it is once a day, the overall cost is the same as Flixotide Junior. So I think this really just shows the importance of this kind of forum, collaboration and discussion and advocacy can bring around quite effective and important changes for children and their families. Just wondering whether there's any questions around this new change, particularly with the more than 6-year-olds.
I think the college sent out some really nice resources with alternative tables for the GPs amongst us as well, Catherine, that you can use. So hopefully everybody has those resources. If not, you can find them, I think, on the RCGP website. Again, not to pick on anybody, but Kerry might know more about that. Kerry Hancock, who's with us this evening. But yeah, hopefully everybody is getting more familiar with the alternatives. And it won't be too much longer. I don't know if anybody's had any issue with prices. I know there's been a huge price variance. And I think we said initially, Chemist Warehouse, there wasn't too much of a cost difference unless you're on a healthcare card. But yeah, it remains to be seen whether you have to shop around a bit for the foreseeable months.
And I think the next, just highlighting some of the impact we have made as a community of practice through some of the discussion regarding the asthma action plan, and I think that's highlighted in yellow. There's been changes that Kevin and his team has helped to implement that makes it more user-friendly and more consistent with guidelines with the asthma action plan. And just to say, this is always going to be an ongoing work in progress as evidence change, practice change. And I think the benefit of us working together and having this forum where we feedback and share and have some of the peak bodies on board is to be able to shift the dial, make these changes that really implement changes that affect our clinical practice. So this is, I guess, another example of the impact that we have made as coming together as a community of practice. Does anyone have any questions or want to share the experiences with the asthma action plan and how it changed over time?
Anybody had any difficulties with the changes with the asthma plans or the change in communication with schools? A question I had for Kevin actually was, you mentioned that you were having videos put up on Asthma Australia about the asthma action plan. Would you be able to elaborate a little bit about what those videos are and how we could use them in clinical practice?
Thanks, Kirsty. I've put a link in the chat as to where you can find it. So it's on our asthma action plan page, which provides information about what asthma action plans are. I think that the impetus around the providing a video is more obviously for the consumer, for the patient, as to you know, what the purpose of an asthma action plan is, where you can get it, how you use it. So it's really an introduction to asthma action plans more generally. I must say that just going your point about the schools, I think that will be, and as Catherine mentioned, it's an ongoing collaboration when we go into ICOM Sustain, that we will be mindful of what the schools are doing, because we still do get some schools that may wish to use some older versions of asthma action plans, or they've and some of them are our own old versions, which we've now taken away from circulation. So it's an ongoing process of education for the patients, and I think it's really trying to upskill and acknowledge the patients to make these changes sort of patient-driven at the GP practice, so that they will, you know, ask for the appropriate plan, and that they don't. I think very early in the piece, I remember Catherine and another GP saying that you know, patients were coming into EDs confused about having to have maybe it's one or two action plans, a different one for school and a different one for personal use, and this was often quite created a lot of stress for them, and perhaps, you know, repeat visit to the GP, and also an unnecessary visit to the GP, really, just for something that was really just administrative. So hopefully we're on the right track to resolve that, and yeah, we're still. I think the door is still open about asthma action plans and how they look, and yeah, what sort of what GPs would like to see, what the patients would like to see, and yeah, so we're certainly open to continuing that discussion in the future COPs.
Thanks,
Thank
Kevin.
you so much.
And I think I highlighted a lot of our project through ICAMs about listening to families and responding to their needs. And I think Asthma Action Plan and trying to simplify it and having down to one rather than two have a lot of been driven by families. But as Kevin has said, it's going to be a work in progress as we transition to this. I also want to highlight that part of this project was also developing resources and really interactive educational resources, as we mentioned about the Asthma Action Plan videos. National Asthma Council also helped us develop some resources. That's educational package, one for clinical staff and one for non-clinical staff, for example, for schools and also for sports club. So Narelle, if you're online, she will add the link to that if anyone's interested in trying it out. And I believe for the GP one, you can also claim CPD points for there too.
I would like to just say for those of us who work in the community, some of the changes that you might not have been aware of since the beginning of the year. I'm sure everybody here will be familiar with the Victorian Schools Asthma Action Plan that was available through the Asthma Australia website. That has now been removed. The reason being Victoria was the only state, and again, correct me if I'm wrong, Kevin, that actually had a specific school action plan. And this is somewhat we're talking about, maybe asking too much. I think the communication from schools I've had, and that's from teachers working in schools who are patients and also who speak to me when I speak to them about asthma children, is they're not health professionals. And really all we're asking schools to do is know a child is asthmatic, make sure they have access to their Ventolin and help administer it, and make the decision whether it's their parent or an ambulance is called. They don't need to know complexities of their asthma care plan. And really that Victorian Schools asthma plan was almost like a bookmark to say this child has asthma. But they were filled out almost identically by most GPs, and it very rarely involved an asthma review. And certainly my experience was in January, early February, having an influx of panicked parents being told that they can't go to school because they don't have an asthma plan. And you'll note in the top it says plan date and review date, and a lot of schools in my experience read that as expiry date. And I've been signposting parents more and more to the Victoria and schools to the Victoria Education Authority guidelines, which are the plans do not expire. So if a child has a plan, it's a valid plan. They do not need to be given in colour. They can be given in black and white. The parent doesn't need to go home and find a colour copy. And there is no need for an independent school plan. And experiences of that have been, especially in the daycare sector, parents being sent home with a perfectly well child unable to go to school, paying for a day's daycare and losing a day's wages. So they're about $1,000 down by the end of the day. Because they don't have a in-date asthma plan. When they do, they just haven't had a review. And then parents being quite pushy to get it reviewed because daycare won't let them go, and me saying, well, you didn't bring the child in, you didn't bring their inhalers, you didn't bring their spacer, I'm not going to do a review because I can't do a review. That's filling in a piece of paper for paper sake, and then potentially don't come back. So what I've been doing is writing a letter and signposting to the VicEdu website saying, please review the VicEdu guidelines. They have a date, a plan. It is in date. It has not been reviewed because I've not reviewed the child, but they are able to attend daycare, and sometimes an amendment, please refund the daycare fees that you've charged them for the day. So that's my experience of it. And from general practice, now I've been explaining that it's still a work in progress and they will change, but really that school just need to worry about knowing that the child has asthma or not, and making sure that they have a plan, not that the plan expires.
Thanks, Kirsty. So moving on to the 6th community of practice. In this one, we spoke about more difficult to control asthma. I think Shiv again joined us and talked to us about some of the more rarely used puffers that we don't see, and the biologics and referral pathways. Some of the key messages were that it's really about reviewing the diagnosis. Is it truly asthma? Checking the technique, often with improvement in techniques. Sometimes they don't need the doses that they were on and they were responding to the medications. And I think for a very small number of patients that are truly difficult to control asthma, after you control all the comorbidities, other allergies, that these rarely used puffers and also biologic can really be life-changing. So the pathway for referrals are specialist respiratory clinics. So the Children's Hospital and Monash both have specialist respiratory clinic to see these children that we feel that we're up, and typically they're up to step 3 in the International GINO guideline. You've gone up to the highest step of double dose of your standard inhaled corticosteroids. With good technique and managing everything else, they're still not responding. Those are the patients that need to be referred to the specialist asthma services. Kirsty, do you want to share your learnings from this one?
A plug for Health Pathways. Health Pathways Melbourne has really good resources on how to refer and when to refer. Shiv really did say 80% of what he sees is reviewing the diagnosis. It's good old-fashioned medical student style history taking. What is causing this cough? What is causing this breathlessness? I think a recurring theme for the community of practice, especially in the probably 5 to 12-year-olds, is breathlessness in the school setting, which can be lack of physical fitness, and really going through exercise-induced asthma. And for him, his key points are if they're sitting down and they're settling within 15 minutes, this probably isn't asthma, but if they're still coughing and feeling tight in the chest, up to a couple of hours later, it's more likely to be asthma related. And also it's not something that will necessarily come on after, you know, an hour's lesson of sport. It's usually at peak physical intensity, or a few minutes of sport, you know, a few minutes of running around and they're already breathless. It's probably physical fitness. If they've actually done more than the warm-up, shall we say, and then their symptoms are coming on and staying on, it's more likely to be asthma. And the biologics for me was really interesting, the lack of side effects, the life-changing nature that can be, and some of the stories that he said and shared with us, which we were really privileged to hear about how children have come and said, my childhood, I could have had my childhood, I think were the words he said, if I'd been on this medication before. But unfortunately, funding, as always, is prohibitive in making these medications more widespread.
Interest of the time, we might just press on because we're at 7:30 at this point. So the next, actually the last month one was on the environmental impact on asthma and vice versa. I think for this community practice, we remind that the origin of this ICAM was funded on the inner west, mainly because of the understanding the amount of pollution in this area and the impact on children's, particularly respiratory health. We have a sister project called Breathe Melbourne. They're on a research project understanding the exposure of children to pollution as they walk to and from school. The related projects including Idling Off, where they have education program where they trial getting parents to turn off their car what they are waiting to pick up children or their stop. So that hopefully the team will be able to share the results with us shortly, but there's a lot of work going in the background, how we reduce the environmental impacts and therefore the impact on health in children, particularly living in the inner west. On the flip side of it, we also had Dr. Brad Montgomery joined us last session, and he spoke to us about the carbon footprint that we lend to the environment by using some of our asthma treatments. So as you all know, the metered-dose inhalers such as salbutamol and Flixotide do have a bigger carbon footprint compared to the dry air inhalers such as the Symbicort. However, in children, it is still important to emphasize that many of them do not have the technique to use a dry air inhaler, and it's much more important that we control the asthma well, because going to hospital is a huge carbon footprint. So I think the priority is getting a diagnosis right getting the technique right, reducing treatment if they no longer need it, and only for those children, particularly closer to adolescence, late primary school, that can use the dry powder, that will be the group that you'd be thinking about changing over. So we shouldn't be banning metered dose inhaler, but about mindful about prescribing was the main key take-home messages for me for this one. Kirsty?
Yeah, I think you've covered it well there. It was an interesting perspective. It's a conversation that isn't talked about much in medicine, our carbon footprint, and I think it's emerging. I think it was important, again, with the ethos of our community of practice and the holistic view we have, to include something on the environmental impact. I was also saying, working in Melbourne, slightly outer west, it's something that with a huge number of migrant population, people ask me all the time, because we quote the fact that, you know, Melbourne is one of the biggest allergy and asthma capitals in the western suburbs, or the capital of the capital. And people ask me, even without me stating the fact, should I move? Often people will go to other places, go to other countries, and come back to the big city and say they didn't have symptoms there. You know, is it here? So I think it's really interesting emerging point on the Breathe Melbourne data, but then also just being mindful in our practice, if we can switch to our breath-induced inhaler, then we should be.
Okay. Fantastic. And I think that just covers all the 7 wonderful topics that many of you have joined us, every single one of them today. So let's open the floor now to see if there's any questions first. Questions or feedback? Happy for either.
And the questions don't need to be about what we've talked about today. If you've joined this evening for the first time, for whatever reason, and you've got clinical questions about asthma practice, we've brought lots of cases up, and very happy with the shared pool of knowledge to answer any clinical practice questions that may have come up recently for you. I think this is the quietest we've had the group.
Yes.
Stunned silence is what we've achieved, I think.
Well, perhaps we might move on to Rachel if you like. Okay. Oh, would you have a question that comes through? It's from Melbourne. Besides GP, who can we refer patients to for assessing hay fever and thunderstorm asthma? I think for the first referral would probably still be GP. I think, Kirsty, if you agree, because it is very hard to get into an allergist at this point. And I know from the Children's Hospital, the Upper Airway Clinic, the waiting list is so long that often, unless you've tried and maxed out the doses of the nasal steroids, often they won't take the patient. So I think the first referral would be the GP. And I think most of the time, with the nasal steroids, you will see a good improvement without needing to be referred to specialist service.
Yeah, I think that was echoed by the thunderstorm asthma COP that we had, really similar to Shiv's presentation on complex asthma. So much of this we think is sort of wonderful interventions of magical things we don't know about it. Actually, a lot of it is just doing good medicine, good basic medicine well. Health Pathways is another incredible resource, as is the RCH, the resources that we put up in those previous slides, to manage things like hay fever and allergic rhinitis. It's a question I'm asked multiple times a week, every seasonal allergy season, is can I see a specialist? Because people really want to see a specialist, but I think if you give education well and follow the protocols, they respond. And I've not had to refer to a specialist yet. So I think it's just really giving consistent, clear education. Nobody wants to use a nasal steroid for 6 months, but they have to. And I often tell my patients that rhinitis is a heart sink thing, not for me, for them. It's one of these conditions that you say, oh God, you've got rhinitis. look, it's really problematic, you give the education, but really, same as if I said you're on asthma and you're on your Flixtide for 6 months, you're on your nasal steroid for 6 months, to give it a really red hot go before you're thinking about seeing anybody else.
Thanks, Kirsty. Wendy has put in a good question. So for older children with exercise-induced wheeze, would you suggest to using Ventolin or Symbicort inhaler? That's a really good question, because we often hear from teachers and families that children have asthma and often they don't want to participate. I think the messaging here, we need to be able, and we should be able to control asthma really well so that children with asthma can participate in all the sports that they enjoy. And so I often put into their plan, if Ventolin is what they use as a reliever, I often put 2 puffs before exercise. And if for the older adolescents that are already on Symbicort, I would put the Symbicort 1 puff before exercise, and that's often very effective way. So that's a great question. Thank you. So Belinda had put a lovely question on there, and I invite all of you to have a think. For those that have joined this evening, or maybe those have joined a previous session, what is the one thing that have changed or will change in your management of asthma? Because all of us here manage asthma in multiple different ways. Some are clinical, some are non-clinical. After attending today and hearing about the things that we discussed, would there be one thing that would change for you, or what you would do differently? Thanks, Carrie, for sharing that resource. You can put it into the chat.
Yeah, we know that speaking up can be intimidating, and we do pick on people occasionally, but only the old hands who have become part of the community of practice family who are here every month. So
and if it does come to you when you feel in the evaluation, we'll love to hear from it too. So pop into the chat if you could, but otherwise you can share with us on the evaluation. It just help us gauge what kind of things were helpful for each of you. Perfect. All right, well, Rachel, would you like to take over next on talk us through the next steps?
Yes, thanks, Catherine and Kirsty. So my name's Rachel. I'm from Safer Care Victoria, and I've had the privilege of working with Kirsty, Catherine, and Northwestern PHN with establishing this community of practice. And I'm really excited to announce that the community of practice will be continuing into next year and possibly even up to 2026. And so before I go into the details, what I wanted to share with you all is a bit of feedback that we've received from participants, because I know that we have a few people who are new to the group. And so this is the feedback that we received from attendees. And the first table there sort of highlights how people felt about the learning outcomes and whether it was entirely met, partially met, or not met. And as you can see there by a lot of that green, a lot of our attendees felt that the learning outcomes of the sessions were met. When it comes to recommending this activity to a colleague, 69 out of 70 of the participants said that they would recommend this activity. And I think very importantly, around change in practice, and we found that 53 of the 70 participants who filled out the survey said that there was something that they would change in their practice. And when we looked at sort of theming the data, a lot of it was around provision of care, engaging with consumers, and also being able to access some of the resources and tools that were shared in the community of practice. And then finally, around content delivery and presenters. So every attendee who completed the survey felt they was either entirely met or partially met in meeting their expectations, which is just great feedback. And it's because of this feedback and hearing how valuable these sessions are that we've been able to extend this project. So some of the quotes that we heard was around being able to hear different perspectives, being able to be in the room with parts of the health system that you may not always have access to and have conversations with. But as we all know from our everyday to-day practice, we're all still linked together. And so this community of practice provides the opportunity for people from different parts of the health system to come together, to work together and identify ways that we can not just learn from each other, but also improve the system. So it was fabulous to have some of those quotes to showcase that experience that the participants had. And so what I would love is your feedback from today's session. So we have a few additional questions because this is sort of the summative event for this phase of the project. And so if you scan that QR code there, you'll be able to access the feedback form, and love to give you some time now to complete that while I talk a bit about what the next phase will look like. But as you've seen before, the feedback is very valuable. We do look at it and it helps shape what the community of practice will look like. And so hopefully you've all got it, and I believe the PHM will put a link in the chat as well. So ICAM sustain phase. So with the ICAM sustain phase and the community of practice continuing, what we will be doing is we'll be recommencing in September 2023 and be using the next couple of months to really evaluate what the purpose and the goals are of this community practice to make sure that you get the most out of it. We'll also be reducing our frequency to every 2 months. And the reason for that is obviously with the childhood asthma management, there is only so many topics that you can cover. And we want to make sure that when you attend, the content that we cover is relevant to you and your practice. And we're very fortunate that you'll be seeing a lot of the familiar faces, and Catherine and Kirsty will be continuing on facilitating the community of practice moving forward. And the Northwestern Health PHN will be the host for this, which is fantastic to continue with the people that have been part of this work from the very beginning. And while you're filling out that survey, I just wanted to say a few thank yous as well. So again, to the Northwestern Health PHN for being the host and for this, and partnering with Safer Care Victoria to lead this community of practice. To Catherine and Kirsty, who are both full-time clinicians who take the time to host and facilitate. And I think it's so valuable to have people with that real life experience being able to facilitate the discussions that we have today. Of course, to all our attendees who have been so open with sharing their thoughts and their feedback, because without your openness, we wouldn't be able to make the changes that we've seen. All the peak bodies who have been involved, and of course the Department of Health who have funded this piece of work. And on the 21st of June, we will be having an ICAM showcase event. And so when you complete that survey at the end, if you're interested to finding out a little bit more about all the ICAM projects, so community of practice, just one small part of this big ICAM piece, and the work that's been done over the last couple of months, please give us your email and we'll forward you an invite to the virtual event on the 21st of June, which will be held between 5 to 7 p.m. And share to you some of the resources and tools that have been developed to really help improve childhood asthma management in the Inner West. So if there's any more questions, feel free to put that through. Otherwise, I think for the very first time, might be wrapping up early.
Last chance till September. Any pressing questions?
Rachel, do you want to stop sharing?
Yeah.
Thanks.
Yeah.
We would love any feedback on the form on how you would like the next phase of ICAM to continue. And sustainability is the forefront of our mind. We need for it to continue, it has to be useful for the people that are coming. So give us any ideas that you have on how we make this sustainable and importantly useful for you.
Oh, thanks, Mel. That's nice. She loves the community of practice. I think we all do. I think it's been a real sort of theme for everybody who's kept on attending. I see all the GPs out there who are familiar faces and have kept coming. It's been a lovely, friendly, collaborative environment to learn in, and we'll miss it until September, but we'll come back fresh-faced and bushy-tailed and all that to hopefully carry some of these learnings forward and do some more good work.
And I think one of the extra benefits that we haven't mentioned is the friendships that we have made, isn't it? And of people coming back, we now know, that person that we can call on, or that kind of resources. So just familiar faces, networking, and knowing what's in your neighborhood have been definitely extra learnings and valuable asset for me going forward. Thanks everyone for all the lovely messages. So we'll see you hopefully in a not too far future. And thanks for all your feedback and joining us and giving us your evening.
Thank you all. Thank you to the
Thanks,
ICAM team.